welcome. So glad to have you here with us this evening. Please make yourselves comfortable. We'll get started in just a couple minutes as we let folks trickle in. Hello, good evening. See somebody's waving. Hello to you. Hi, Tevis. Good to see you. We'll get started in just a moment. Thank you all so much for coming out in support of 988. This is awesome. Hi, Mary. Hi, Cindy. Give it just a couple more minutes. All right, cool. Well, welcome everybody. Thank you all so much for being here with us this evening and for taking some time out of your busy work week to be with us and to chat about 988. We're really excited. I'm Nova from NAMI Metro Baltimore. I'm the marketing communications coordinator and just wanted to walk you through a few quick housekeeping items. Basically, throughout the duration of this presentation, we'll be hearing from a bunch of really esteemed and wonderful experts in this area. So we'll be going through a couple of presentations, and then throughout, please feel free to use the Q&A feature at the bottom of your screen to drop any questions that you might have. If you drop them in the chat, we'll try to add those to the Q&A, but please just put them in the Q&A section. And then at the very end, we will have an open Q&A where we'll address those questions and just answer any questions that you might have or that might arise. So without further ado, I'm going to turn it over to Carrie Graves, our Executive Director here at NAMI Metro Baltimore.
Wonderful. Thanks so much, Nova. I'd like to just start out by thanking you all for joining us today. So many of you came out to join this important conversation. We are so proud to be partnering with NAMI Howard County and NAMI Carroll County to ensure that our community is educated on 988 and prepared to help us spread the word far and wide about this life-saving resource. NAMI, the National Alliance on Mental Illness, is the nation's largest grassroots mental health organization. We offer education support and advocacy services to help improve the lives of individuals living with mental health conditions, their family members, and our communities. And all of our programs are non-clinical in nature. They are designed to complement the behavioral health care that each participant is receiving. Your local affiliates of NAMI are here to provide you with support groups and educational classes, anti-stigma presentations, resources, and so much more. In the chat, you'll find the contact information. Nova can drop that in there, or our local affiliates, if NAMI and Howard County and NAMI Carroll County have joined us, can drop in their contact information for all three of us that have partnered today to prepare this presentation, so you'll know how to reach us. In just 25 days, 988 will be available as a number for any person to call or text during a mental health, substance use, or suicide crisis. It'll be available throughout our state and across the country. Having this easy to remember 3-digit number will help more people connect to trained counselors during a crisis and save lives. On July 16th, you'll be able to call or text 988 from any phone in the US and connect with trained crisis counselors. They'll be able to help many of the callers over the phone. And this is a great first step, but I don't want to say that this is the end. It's only the first step. The work to help people in crisis is just beginning. Right now, the full system that we need to have in place to respond to people in crisis who call or text 988 is still under-resourced. There's been a lot of work underway, and you're going to hear a lot about that work tonight to increase those services. But we know that every person in crisis needs someone to talk to, like our 24/7 local 988 call centers, someone to respond, like mobile crisis teams, not law enforcement, and somewhere to go, like crisis receiving and stabilization facilities. Today, again, you're going to hear more about the progress that has been made in Maryland, what services are already in place as 988 rolls out, what to expect if and when you need to make that call. And you'll hear about what still needs to be done and innovative new initiatives underway to ensure that we are robustly responding to the mental health needs of our community. Again, as Nova said, please do connect with us throughout the presentation by commenting in the chat and placing questions in the Q&A, and we'll save that time at the end of the presentation to address your questions. And now I am pleased to welcome our first presenters, Dan Rabbit, who's the Policy Director for the Greater Baltimore Regional Integrated Crisis System, or GBRICS, as you'll be hearing it referred to tonight, and Shauna Brock, who is the Director of the GBRICS project implementation. Dan and Shauna, I will turn it over to you, and thank you for joining us this evening.
Sure. Thanks, Carrie. Good evening, everyone. Thanks so much for having us and for being with us this evening to discuss this important topic. Like Carrie said, my name is Dan Rabbit. I work at Behavioral Health System Baltimore, working on the Greater Baltimore Regional Integrated Crisis System. Shauna, do you want to say hello before we dive in?
Sure, I can do that. Hello, everybody. Again, I'm Shauna Brock, Director of GBRICS Implementation, and Dan and I will be tag teaming, and he's up first.
Sure. Yeah, thanks. So next slide, please. So Shauna, in my portion, we want to provide some context on how we got to this point, being on the cusp of launching this new number for Behavioral Health Crisis Response 988. We also want to talk about a very related and coordinated effort around GBRICS, as we've mentioned, and then share a little bit about what things are going to look like once 988 launches, and what we need to do collectively as a community to make sure that the launch of 988 is successful, and that this opportunity that we make the most of this opportunity to help people feel supported and be safe when they're in distress. Next slide, please. So to start off with, the 988 opportunity, it's really something I like to not take for granted, and I want to kind of walk you all through a little bit. Next slide, please. I think while 988 is specifically a new 3-digit phone number for the National Suicide and Crisis Lifeline, it really represents a lot more than that. I think of it as a confluence of a few different kind of realizations or movements even that have been going on in our country over the last few years. I really like the NAMI national tagline of "to reimagine our crisis response system." I think there's a growing recognition that 911, law enforcement, and emergency rooms are not well suited for supporting people who are having an emotional crisis or suicidal crisis. That communities want an alternative response, and that response should be fully integrated and on par with other emergency services. And these ideas, it's taken a little while for these ideas to take root, but it really feels like these ideas' time has come, and the launch of 988 next month really represents like a pretty rare opportunity, a pretty rare moment to transform mental health and behavioral health services. So, to make the most of this opportunity, we can really shift the culture that exists today around how people see emergencies and how comfortable people are in seeking help, breaking down the stigma that revolves around stating that you need help in a mental health situation, and so this is really great to be on the cusp of this moment, and it's really exciting to share it all with y'all. Next slide, please. So what is it at its most basic? 988 is going to be the new number for the National Suicide Prevention Lifeline. The number that has been in place since 2005 is 1-800-273-TALK, and it has helped millions of people. There's been lots of research that shows that the supportive counseling and the emotional support that people receive when making that call is effective. at reducing the risk of suicide, and it has helped millions of people in the 15+ years that it's been active. But there was recognition that that 1-800 number is a little hard to remember if you are really in distress. And so that's where the thought around wanting to have a national 3-digit number that could parallel 911 came into being, and how we landed at 988. Next slide, please. The Suicide Prevention Lifeline has helped millions of people over the years. Last fiscal year, the last year that we have data, we had 3.6 million contacts around the country, 2.4 million calls, 1.1 million chats, and 0.1 million texts. And the goal is to see that expand significantly with the implementation of 988 and the expansion of access to text and chat. We hope to see these services reach that many more people. For folks who are unfamiliar, the Lifeline is accessible 24/7. It's free, confidential. Crisis counselors who answer the phones have specialized training in suicide prevention and de-escalation, more training than people who are not specialized in this field, but it has been shown to be quite effective in helping people through suicidal or other behavioral health crisis. Next slide. How we got here, this is a pretty detailed timeline that we lifted from a SAMHSA slide. So no one's going to be tested on all of these dates later on, but I think it is helpful to see the progression. This idea wasn't in place 20 years ago. And that's pretty wild to me that in the 90s, we didn't have this service at all. And so to go from there to where we are in 2022 with a national 3-digit number that's going to be promoted and lifted up across federal, state, and local government is a really impressive timeline. I think some of the key things to note is that 988 came about due to a Federal Communications Commission study in 2020 that found 988 would be the best number out of a variety of choices. And then Congress passed a law in 2020, also the National Suicide Hotline Designation Act, that established 988 in law, and also set up the structure for how states could fund it, which we'll talk a little bit more about in a moment. But it's been a long road to get here, and it's wild that we're less than a month away from the go live date. Next slide. Some of the advantages of moving to 988. The main thing is that it is a 3-digit number that is more easily understood, or more easily remembered, rather. I think the FCC in the study that they did, they looked at different types of 3-digit numbers or different makeups of numbers. And 988, I think having the 9 at the front makes it kind of more aligned with 911 and more and distinguishes it from some of the other non-emergency numbers like 211, 311, 411. So I think that's part of the rationale behind it. But the thought is that having a more easily remembered number that can become as widespread and as well known as 911 will increase people's access to these life-saving services and supports, and that the more easily remembered number plus promotional efforts by partners like some of you, everyone here on this call. The thought is that this will allow us to reach more people who could benefit from emotional support in a time of crisis. Next slide. So that's sort of kind of where we're at a national level. Each individual state also has to decide how it's going to implement 988. Most states have convened a planning group in 2021, Maryland included, to sort of look at what the Lifeline network that existed prior to 988, to look at that, see if there are any changes that were needed, and see how 988 could be integrated. Maryland decided that there were the state was covered well, that no new organizations needed to become Lifeline centers, but that more staff and more capacity was needed. And so both the federal government and the state government has provided local call centers with some additional funds to hire staff or to invest in technological infrastructure. Not enough, but something to get started with. But we do know that for this to really make the impact that we hope it will, sustainable funding, so that both the call centers and the related services, such as mobile response teams that are needed if somebody needs more than just supportive counseling on the phone. In order to have a system that can really meet people's needs, we're going to need more funding, and it's going to need to come from a sustainable source. So we're not fighting for grant dollars that could disappear next year every time that fiscal year is coming up. A couple things that are just unique to Maryland and to this region. Maryland has a behavioral health crisis hotline system today, which is 211 press 1. That has done very good work, and that's not going away. But ultimately, at some point down the line, the thinking is that the 211 press 1 services and call centers and funding will be consolidated into one unified 988 network. What that looks like, nobody really knows, and no one's worried about trying to do that immediately, but that is something off in the distance that Maryland needs to contend with. And then for our purposes here in this region, in Baltimore City, Baltimore County, Howard County, and Carroll County, the GBRICS partnership has been putting a lot of thinking into how to build a more robust behavioral health crisis response system, and using 988 as the number to access the new regional call center that is being set up and that Shauna is going to talk about in a second. We saw that as a natural alignment. And so 988 is going to be the way to access the GBRICS funded 988 regional call center that is getting set up later this year. So those are some kind of specific Maryland related issues to bear in mind. With that, I'm going to pass it over to Shauna to talk a little bit more about what's happening here in this region.
Great, thanks, Dan. I'm going to start out by talking a little bit about the Crisis Now model, so you can move to the next slide. So the Crisis Now model has really been pretty well established as the accepted model by a number of national organizations, so including NAMI, SAMHSA, which is the federal agency that oversees mental health and substance abuse services, and the National Alliance for Suicide Prevention. And so we'll be talking in more detail about this, but just the general overview, I like that it's easy to remember. It's someone to call, someone to respond, and somewhere to go. And as we talk about GBRICS, we're really focused right now in the first two. So we are standing up a new 988 regional call center, and we're expanding mobile crisis teams. In terms of increased crisis stabilization centers, we don't have the funding for that, but we want to document the need for that. So if there's a need for increased crisis stabilization centers, we'll be able to make that case. So next slide. So this is the Crisis Now model. I love this graphic. I didn't make it, but we've been using it. So you have a person in crisis, and the first step is somewhere to call. And so that will be 988 when that goes live. Of course, some people are still going to call 911, and that's why in most jurisdictions, there's a lot of communication between 911 and crisis lines to try to make sure there's the ability to transfer some 911 calls to the crisis line that would be better served there. And with those calls, 80% will be resolved on the phone. That's the model. Most calls, people can just need that counseling, someone to talk to. When someone does need someone to go to them, that's when we have the mobile crisis teams go out. And the line between the police officer and the mobile crisis teams is that in most jurisdictions, the law enforcement also can directly request mobile crisis teams. And with that, most calls are resolved at that level. But some people will also need crisis facilities. And what we're looking to do is to be able to take people directly to crisis facilities without going through an ER first. So that's a bit of a change for the system. And eventually, I would say in places that have a well built out system, law enforcement also is able to take people to directly to a crisis facility, although that's not really something we're going to be working on right now. And then you need the follow-up care to make sure that people can continue to be served in their community. So in general, we want to decrease the use of jails, emergency departments, and inpatient use, and have the least restrictive care, which is also the least costly care. So that's the model in a nutshell, and then I'll be going into more detail about how GBRICS plays a role. So next slide. And next slide. So the GBRICS partnership, just a general overview, we are a 5-year funded program funded through the Health Services Cost Review Commission, which isn't really that important, but is a different source of funding for us. We are actually in year 2 of that 5-year program. It's $45 million to invest in behavioral health infrastructure and services. And so we really do look at this as an investment, and building that sustainability into it is part of our project. And Dan will be talking more about that later. It was developed in collaboration with all 17 hospitals that are in the region. And the region, again, is Baltimore City and Baltimore, Howard, and Carroll counties. And so the local behavioral health authorities participated, as well as leaders, community partners, and people with lived experience. My organization is Behavioral Health System Baltimore, and we serve as the regional administrative manager for the project, which means we staff the project and manage the funding. Next slide. So our overall goal is to reduce unnecessary emergency department use and police interaction for people in behavioral health crisis. And these are the main elements that I'll be going into more detail about, but it's the regional call center, expanding mobile response teams, supporting open access services, so I'll go into more detail about that later. Community engagement and outreach. So really we're trying to support that cultural change to increase awareness and use of 988. And we also have nonprofit multi-stakeholder oversight. Next slide. These are our guiding principles. So, and our vision, which was developed through our GBRICS Council. So establishing behavioral health care as a fundamental element of emergency response and suicide prevention. And in addition to the Crisis Now model that we heard earlier, advancing equity is important to our project. Ensuring timely access to care, standardized approach throughout the region, and involving communities and stakeholders. And of course, our project has changed as we've gone along, as we've incorporated that community input, and really to use data to drive decisions so that we can both improve experiences and really show that this has a clear return on investment, so that we can continue to have these services funded at the end of our project. So next slide. So now I'll talk a little bit more in detail about each of the elements. So our call center will be one regional call center for the for the whole GBRICS region. I briefly saw a question in the chat. It will be for all ages throughout the lifespan. So it is meant to be one access point for everyone. And as we mentioned, there's a lot of services we need to continue to build out. So we do need to build out, continue to improve on our services for the whole lifespan. One thing that's going to be different about our call centers, we're really going to make the best use of technology. We are buying new software that's going to offer real-time coordination and real-time data and real-time access to resources. So we'll have a data dashboard that'll help us improve accountability and performance improvement. We will also be able to dispatch mobile crisis teams from the call center directly using GPS dispatch. And we will also be able to connect people directly to crisis beds, to the crisis beds that already exist through this project. And we're anticipating a soft launch for this in October of this year. And so that is a little bit later than 988 launches. 988 will continue to be served by the existing Lifeline centers until we get this up and running. But we are continuing to build this out, and we did not make that July deadline. Next slide. So mobile response teams exist throughout the region. Our goal is to strengthen and expand those. So we are adding additional teams, adding 24/7 coverage to some of the regions. We eventually will intend to have specialized teams for children and youth and potentially other populations. One thing that we've been working really hard on over the past year or so is developing regional standards. So unlike the Lifeline, which is a national program with national standards, there are no state or national standards for mobile response teams. So we developed our own for the region, and you can find those on our website, which I'll put in the chat when I'm done speaking. A big change also with the Crisis Now model is to each mobile response team will have a behavioral health clinician and a peer. And while peers are incorporated in some of the jurisdictions in our region, not all of them. So it'll be a change for some of us. And the mobile response teams will be dispatched through the call center. And we have a pilot that's going to be starting in November of this year. Next slide. So our project is a little bit different than a lot of other projects in the country in that we are incorporating open access for ongoing behavioral health outpatient services into our project. So if someone calls the center and they don't have a need that's gonna, require more intensive care, if they just need to get into outpatient behavioral health care, our goal is to be able to link them with an appointment the next day. And of course, we have to build this out. And the way we're building this out is through an open access pilot program. So we're helping existing outpatient providers to offer same-day walk-in or in-person walk-in or virtual services. We have a technical assistant consultant to help them with that, as well as seed funding for any technology upgrades or staff training that they might need to get that started. And we are looking to work with 34 clinics over the next 3 years. We started working with 5 and we're working on identifying an additional 13 so far that we're working with to build that out. Next slide. So as I mentioned, community engagement is very important to us to build broad and meaningful partnerships. And as we've been going along, we have been incorporating that feedback into our implementation. So it's really, community engagement is to spread that cultural change, but it's also for us listen and to change our work as we go along. And I think at some point we will be putting a link to a chat for our if you're interested in hearing the results of our community engagement. We are having a webinar on Monday about that. Next slide. And the multi-stakeholder accountability structure I mentioned. So our council includes hospitals and community leaders and our local behavioral health authorities. We have open meetings that meet at least quarterly. And in addition to the council, we have our standing committees, which include policy and advocacy and community engagement, as well as other short-term work groups. We've had a number of those as well. Next slide. So this is where we are with implementation. As I mentioned, we've identified open access pilot clinics, and we started working with them. We have issued our mobile response team RFP. We're actually close to identifying a vendor for that. The call center operator has been identified. We're still working on contracting, so we haven't announced that yet. And again, 988 launches in July, which is coming up very soon. And that's when we will start promoting. And Dan's gonna go into more detail about that. But really our soft launch for our services are this fall in October and November. Next slide. So what happens when you call 988? And I know Quinina is also going to talk about this. I'm kind of giving a higher level overview. So next slide. So right now, when you call the Lifeline, or if you call so already when you're calling the Lifeline number, and this will stay the same with 988. 988 is not one large national call center. It's answered by trained counselors at local centers. And if you can either press 1 for veterans, the veterans line is a national call center, or you can press 2 for Spanish, and that goes to a certain sub network. Otherwise, if you don't press a number, you're going to go to your local center. Although if they're not available, it will roll over to a national backup center. So their experienced mental health professionals provide free confidential services for 24/7. Maryland actually has a really high in-state answer rate. So 85% of our calls are answered in state. And I know everyone's goal is to continue to increase that so we can answer most of our calls locally. And so this is just a brief overview of all of the different Lifeline centers in the state of Maryland. You can see our local area is BCRI, Baltimore County Crisis Response, which is operated by Sante, and Grassroots. And that'll be somewhat changed and consolidated as our regional call center rolls out, but the map will stay pretty similar. Next slide. So again, what happens when you call? We try to have it follow this crisis now. Most calls are resolved on the phone through counseling, safety planning, linking to resources. And again, this is just an approximate number. About 20% require in-person mobile response team. And then we also, all Lifelines providers screen for risk. And it's less than 1% that would require active rescue, which really means sending law enforcement and EMT out because there is a active suicide attempt in process. Next slide. So what will change with 988 and GBRICS funded programs? So really what we're hoping to do with GBRICS is to increase the number of call operators, to increase even more the number of calls that are answered locally. And if staffing allows, if we're able to recruit, we would love to include more calls that are answered by Spanish-speaking operators so that we can become a Spanish sub-network. We want to increase the speed of answer, and I know Lifeline has set a really high bar for that we want to meet so that calls are answered. I think the initial goal is 90% of calls within 30 seconds, moving to 95% within 15 seconds. So really just making sure that call gets picked up immediately. And as I mentioned, we want to improve the linkage to care for outpatient visits and crisis stabilization facilities. And now that I'm thinking about it, the other part that we want to do is to increase mobile response team capacity to also answer those calls quickly. And I think that, yep, that's my last slide. So turn it over to Dan.
Yeah, thanks, Shauna. So it's a lot of really exciting stuff. You know, I think at a high level, we hope, you know, people will get better care, you know, and people, you know, and fewer unfortunate, you know, disruptions in people's lives or people not being safe will occur. But in order for any of this to work, people need to know about 988 and trust that if they call 988, they're going to have their needs met. And so an important component to this entire effort, both 988 implementation and GBRICS implementation, is around promoting 988 and raising public awareness of these services. And that's why it's so good that this webinar is happening, because we need everyone's help. We need the NAMI affiliate network and people who are interested, people who are advocates in mental health issues are going to be so important to succeeding. Next slide, please. You know, right now, most people are not familiar with 988. This statistic here is from November of last year. I think it has improved a little bit, but at least as of November last year, 80% of people surveyed had never heard of 988. And only 1% of people surveyed were very familiar. I think I did see a poll that came out like a couple months ago that said maybe a third of people had heard of 988 at that point. But regardless where we sit right now, we definitely have a lot more work to do. You know, everyone knows about 911. We want 988 to become that well known, and we have a long way to go to get there. Next slide. The way that the GBRICS partnership is approaching that is that we built in, as part of our community engagement and outreach efforts, plans to do market research and to use that market research to plan and implement a outreach and education campaign around 988. We selected Marketing for Change to be our market research firm, and they conducted robust market research over the last year or so, and have used that information to help us come up with a plan for how we want to promote 988 in the near term and a little bit further off after this initial phase. Next slide. One thing to note, just so we're all on the same page, we are not doing like heavy promotion of 988 until after July 16th. Right now, if you call 988, you'll probably get patched through, but telecommunication companies are not required to be able to do that patch through until July 16th. So we don't want to give people the wrong impression. So we're educating partners and getting the word out in the run up to July 16th, but we're not doing any paid marketing until after July. Next slide, please. So some of the initial findings that we learned from our market research efforts is that there is a lot of goodwill around the helpline. People are comfortable with the idea of 988. They're glad it's happening, but there are very high expectations. You know, people hear about this and they are envisioning a certain level of service, a certain level of responsiveness, a certain level of respect. And so if 988 rolls out, people don't have that kind of experience, we could lose that goodwill pretty quickly. Beyond that, I think the biggest barrier that we're facing is that people are unsure of what to expect when they call 988. People don't want to lose their autonomy. People don't want to escalate a situation. People don't want to reach out for a mental health response when maybe they need a more intense response, and that the mental health, the lifeline would not provide the level of safety that people need. So that uncertainty, that unfamiliarity with the process of accessing a crisis helpline is something that we need to address if we want people to feel comfortable with 988. Next slide, please. One aspect that came out of the market research very clearly is that there is stigma for seeking help. We've made a long way. We made a lot of progress. NAMI has been at the forefront of that progress and destigmatizing mental health conditions and mental health help seeking, but stigma still persists. The stigma is more prominent when it comes to seeking help for yourself than for helping a loved one, and the stigma is more prominent for substance use than it is for mental health. And so, chipping away at that and continuing to normalize and help people feel comfortable with the idea that everyone has, that many people will need help at one point or another in their lives for mental health or substance use, and that seeking help is a sign of strength, not something that people should be ashamed of. That's something that we're going to try to take head on in our promotional efforts with 988. Next slide. Another, just to emphasize the goodwill, there is a lot of goodwill for 988, more goodwill than there is for 911. Although it should be mentioned that 911 has a lot of goodwill too, which is a good thing. We want people to feel comfortable seeking help through any channel if they need it. And it's good that 911, which has been the preeminent way to seek help in an emergency, has goodwill as well. But 988 or mental health helpline is more positively regarded and has much less aspects that cause fear or being scared or being worried about what might happen. Next slide. And when it comes to the key barrier, people don't like that they don't know what's going to happen. They definitely don't want to be put on hold or have a disappointing experience. If you're in a state of mind where you think you need to reach out to a helpline and you do not receive a responsive, timely, respectful experience, that could be a really hard thing to handle, a hard thing to take. And so that's an aspect of the not knowing what to expect that plays a role. And fear of overstepping boundaries or making things worse. It is a fact. Like you can't guarantee someone that if you call 988, under no circumstances will law enforcement or an emergency petition occur. Like that is a possibility. And so kind of balancing, trying to set people's mind at ease while being transparent about the possibilities is a challenge that we'll have to overcome. Next slide. And so with all of that information, we pulled that all together to come up with an outreach and education campaign. Our primary goals are to destigmatize help seeking, establish 988 as the go-to resource for behavioral health support, and increase general community support for 988 and related services like mobile response teams and stabilization centers. And we're going to use a multi-pronged approach to do that. We want a robust local brand for 988 in our region. We want to use well thought out language, positive language like strength and bravery, and avoiding language like struggle and crisis. And we want to use a phased approach where we start off kind of with a slow roll or a soft launch and only add in new tactics as we're sure that the system is able to provide, has the capacity to handle the call volume that they're seeing. Next slide, please. So the initial strategies for this outreach campaign, we're going to have a website, 988helpline.org is the website URL. It's not live yet, but we're working on it. We're going to have branded print materials, flyers, one-pagers, magnets for partners to share at events or have in their lobbies. We'll have a paid Google search campaign. So if someone looks up crisis or suicide prevention or Lifeline, we want them to be directed to our website. We're going to work with local news media around the transition to 988 in July. And we plan to develop a further set of webinars to build partner understanding and capacity around the campaign. So that's what we're looking at in the near term, the next couple months. Further down the line, we're looking at paid media. We're looking at working more closely with partners around tailored strategies for the communities that they serve. We're looking at digital strategies, kind of everything under the sun. But this is where we're going to start, and we're not going to move on to those new tactics until we're sure that we're continuing to meet that answer rate, that the staff that are at our local call centers are able to handle the call volume, because we are expecting an increase in call volume come July, and maybe a further increase as some of these promotional efforts get underway. So that's what we're thinking about for our promotional campaign, and definitely plan on staying in close contact with all of our friends at NAMI as we launch these efforts. Next slide. So promotions and public awareness is key to our success. The last thing we want to talk about that's key to our success is policy and advocacy. We've mentioned a few times sustainability. Sustainable funding is not going to happen on its own. And so we have established a campaign called the Fund Maryland 988 campaign that maybe some folks on this call are already familiar with, but we want to talk about the successes that this campaign has had so far and what our future goals are as 988 implementation continues. Next slide. The Fund Maryland 988 campaign, we established it in partnership with other advocacy organizations in 2021, and there's a website for that, and there's some social media that you might have seen that are over here on the right hand side, and we developed some resources to help educate our elected leaders about 988 and start making the case for funding of 988 local call centers and the related services that are needed to support anyone who may call a helpline. Next slide. And we had a lot of initial success. I think we were all very happy with where we landed. We drafted a bill, HB 293, SB 294 was the cross file in the Senate that passed unanimously. The bill established 988 as the state's behavioral health crisis response helpline, and it created a 988 trust fund where money can be deposited, and that money can be used to fund both call centers and other services that are important to the crisis response system. $5.5 million will be deposited the next fiscal year. We also acquired $5 million for this fiscal year, specifically for call centers, and $2 million additional dollars to support the GBRICS partnership. So there's a lot of funding available this year. That certainly helped, but still to get that level of funding is a good sign. In the budget, there was also language directing the state to do a gaps analysis of our crisis response system, and that analysis can be used to determine what our future funding needs may be. The federal government, SAMHSA, provided $1.8 million for call centers. Maryland is exploring Medicaid reimbursement for mobile response teams. And all of this just is a good sign that we are well positioned for future efforts to to acquire sustainable funding. Next slide. And that sustainable funding, just to explain it a little bit, the congressional act that established 988 allowed states to enact a small telecommunications surcharge to fund 988 and crisis services. This is the way that 911 is funded today. You maybe have seen on your cell phone bills, there's a 911 fee on there. It's small, but having that fee that generates revenue every year and it allows the 911 board in Maryland to plan and to have funding that it can depend on really is a game changer for 911 and is part of why 911 is so robust, whereas other services are kind of scrapping for funds all the time. So ultimately, that would be a really good solution for how to sustain crisis services and the 988 system. And so, we're thinking about like when it might make sense to pursue that. And we have a lot of opportunities around there. The Fund 988 campaign, Fund Maryland 988 campaign has over 70 members. The trust fund bill passed unanimously. Mental health issues are more prominent now than really at any time in my career. And so all of that points to potential success in identifying sustainable funds. But, enacting a new tax, and that's what it is, even though it's small, is never super easy. There are many other competing priorities besides just crisis services. 911 increased its funding, its fee recently, a couple years ago. And so that just kind of shows that like it's not a done deal. Only 4 states have enacted this surcharge so far. And so we may have to think about other creative solutions, but we're in a good position to pursue that down the line. Next slide, please. And so the number one thing you can do to help increase our odds of identifying sustainable funding is to join our campaign. We made a lot of progress this year. We went from not existing to having over 70 organizations and acquiring over $10 million for our priorities over the next 2 years. And so that's a good sign, but we're going to need even more support. So if you're interested in joining the campaign, getting on our mailing list, helping us to strategize and advocate for new funding and new policies that help support 988 and crisis services more broadly, please email md988@bhsbaltimore.org. You can also visit our website. I think I saw that dropped in the chat. It's just www.fundmd988.org, and follow along on social media and reach out to me if you're interested in more information. We're kind of taking a breather over the summer, but when fall comes around, we'll start ramping back up to determine what our priorities are going to be. So that's just some of the policy efforts that have been going on. Just want to leave you with a quote. Shauna mentioned community engagement. We've done a lot of community engagement. We've talked to a lot of folks through roundtables, through surveys, through one-on-one discussions. And so this quote this speaks to me. It's from a female participant in Howard County. Says, this all sounds freaking amazing. De-escalation, trauma-informed care, helping you get safe and supportive help. But you have to put it into action. Make me believe it. Show me what you can do. And that really is the sentiment that we heard from a lot of people, is that like everyone likes what they're hearing, but maybe they've heard it before. And so we really need to like put our money where our mouth is. And that's what we plan to do. And it's so good to share it all with all of you. And I'm happy to answer questions about everything as we move along.
Wonderful. Thank you so much, Dan and Shauna. We are proud partners of Behavioral Health System Baltimore, and We appreciate all of the work that you all have put into both 988 and the GBRICS project. So thank you so much for joining us tonight. We're getting a ton of great questions in the chat and Q&A. So we'll be back to you two in just a few minutes for that. But first, I want to turn this over to Cornita Garrett, who is the Director of Call Center and System Coordination with with Baltimore Crisis Response Inc. We are also a longtime and proud partner with BCRI, who is our local call center provider here in Baltimore City. So Cornita has joined us tonight to share a little more with our audience about what to expect when you do place a call to 988. So I will turn it over to you, Cornita. Thanks for being with us.
Thank you. Good evening. My name is Cornita Garrett, and I'm going to provide a brief overview of the calls that we currently receive on Lifeline and some potential outcomes that could possibly happen. Before I go over our Lifeline calls, I'll just provide a brief overview of BCRI services. Next slide, please. So BCRI, we operate a 24/7 mobile crisis team that responds to behavioral health crisis in Baltimore City. When they do respond, if someone is eligible, the mobile crisis team can also transport to our 21-bed crisis stabilization unit, where someone can normally stay between 7 to 10 days. During that stay, they receive 24-hour nursing, see a psychiatrist daily, receive medication if needed, and attend groups and receive therapy. We also have a 19-bed 3 to 7 day detox unit where individuals can come on for detox from opioids, alcohol, and benzo detox. And we have the Law Enforcement Assistant Diversion Program. This is a program where individuals who commit low-level crimes such as prostitution or marijuana possession can opt in to receive case management services versus going to jail. And we're also a part of the crisis response team, the CRT, which is an officer clinician co-responder model in Baltimore City. BCRI employs the clinician on that team, and they respond to a higher level of behavioral health concerns that may involve a level of violence that our mobile crisis team wouldn't be able to respond to. Next slide, please. So we have our 24/7 Here to Helpline, where individuals and families can call in for emotional support. They can also call in for information and referral, suicide prevention or de-escalation, crisis support. Crisis support can include mental health concerns or anything from dental pain to grief and loss or to someone being stranded somewhere. The Here to Helpline is a part of the National Suicide Prevention Lifeline. We take between 55,000 and 65,000 calls a year. About 7% of those callers are local 988 Lifeline callers. However, we do receive calls from out of state as well. So on our Lifeline, we receive first and third party calls. It ranges in age. We've had callers as young as 7 and callers as old as 98 call. Typically, when someone as young as 7 calls, is normally to tell on their parents, my mom won't let me play outside, my mom made me mad, or to talk about their school day, because we do receive calls from adolescents related to bullying as well. Next slide, please. So when a Lifeline call is answered, you never really know what you're going to receive on the other end of the phone. Counselors will answer the phone and have a caller seeking resources for outpatient clinics. Then they may receive a caller who calls because they're sad, they're hurt, their pet died, their relative passed away, to someone calling, screaming and crying on the phone and threatening suicide. With Lifeline, there's no wrong call for Lifeline, and it doesn't necessarily have to be a crisis or a suicide call for Lifeline, because we receive a ton of different call types on our Lifeline. One of the major call types is for emotional support, and emotional support can include individuals going through a divorce or relationship issues, and that's a call type that we receive often. Calls related to family conflict and disputes, financial concerns, mental health concerns or substance use concerns, third-party callers concerned about a friend, a family member, or a bystander that they've observed. People call related to school concerns, school resources, financial assistance. Parents often call seeking support related to conflict with their children or advice as to how they should talk to their children. We receive requests for wellness checks, mobile crisis teams, grief and loss support. We receive a lot of calls related to grief and loss. People are often seeking support, not necessarily mobile crisis team, but just for someone to listen. They often want to talk about their relative or their family member or the person that they've lost, or just someone who is calling to vent and have someone listen without passing judgment or giving their opinion. People often don't want your opinion. We have suicidal individuals call in, they want help working through that moment or just help learning different ways to cope through what they're dealing with. We also have individuals who call, they may be angry or upset and they just need to vent about that. Another call type that we often get is people having panic attacks and needing help to calm themselves down. We often, so since probably 2020, we received a ton of calls related to concerns around the world, such as COVID. We receive calls on Lifeline from people who are just tired of being isolated or just tired of the whole COVID thing. We recently started receiving calls related to the war in Ukraine, gas prices, political concerns, and so on. Next slide, please. So Lifeline calls, they can be as short as 5 minutes or as long as 3 hours or more, depending on the severity of the call. Questions we are often asked when someone calls is, what should I say to my child who's feeling suicidal? Parents are often concerned about their child and they want to make sure they're saying the right thing to them and being supportive, and they tend to need support themselves when they're going through that type of situation. We also get a ton of calls from family members. How can I help my mother, my brother, my uncle, who doesn't necessarily want help? Callers call concerned about their relatives, specifically related to substance use services, and it's normally related to a relative that refuses to seek help. People will say, I feel panicked, I don't know what to do, what should I do? We often receive calls from individuals having severe panic attacks and feeling overwhelmed due to job loss, a mistake that was made on a job, or infidelity. People call asking, how can I get my family member into substance use services? People often want to know if they can send their family member to a provider without their consent. Often with those calls, the counselor really just provides support to the relative, and if possible, they can attempt to do a follow-up call with the family member of concern. And we also get a ton of calls on Lifeline related to interventions, substance use interventions. Family and friends often want someone to come out to their home to assist them with substance use interventions. And we often are told about the TV show, I think it's called Intervention, and people want to know if they have that same service in Baltimore City. And a big one is really, I don't know what to say. I don't know how this works. Can you tell me what the next steps are? Callers often, they don't know what to say when they call. Occasionally individuals will ask, like, what do I say? What do I say moving forward? Calling the Lifeline for some people can be intimidating, and for some people it can take a ton of courage, and it can be difficult to know how to start that conversation. And another big one is this confidential? Individuals want to know that when they talk to the counselor, it will remain confidential, that the counselor won't call their job or their family member or a neighbor without their permission. Next slide, please. So when someone calls the Lifeline, some possible interventions can include supportive counseling. The supportive counseling is really just active listening and validating the person's feelings and just being non-judgmental. Often we find that people call because they feel that they can't talk to their family members or friends, or they often feel like they're a burden to their family members or friends. Counselors can also provide support on how they should talk to their relatives or their children. They can do mock scenarios, and just give the person advice on how to approach their relative in a caring manner while reinforcing their concerns. People, they can receive outpatient resources for mental health or substance use, or some people also call for primary care physician resources as well. A mobile crisis team can be dispatched if needed. The counselor can complete a substance use referral, or they can refer us to substance use services. And as I stated earlier, support through an anxiety attack. We receive a ton of calls through Lifeline related to anxiety. We often have callers who utilize the number on a regular to help them through situations that they tend to feel overwhelmed by. We do support on the Lifeline through suicidal thoughts and de-escalation. And when this happens, the counselor, they're going to ask several questions to determine what type of intervention is needed and to determine acuity. There's no specific order to the questions, as they're going to try to just make it a very natural conversation, and so it won't really feel scripted. Questions are also asked to determine if a mobile crisis team is appropriate for the caller or if the call can be handled on the call center level. Next slide, please. So mobile crisis teams, we have the ability to dispatch a mobile crisis team for 988 calls as well. The team consists of a registered nurse and a licensed therapist or a social worker. They can respond anywhere in Baltimore City. They respond in a regular SUV with no labels, and they normally respond in clothing where you can't identify the agency. The mobile crisis team, they conduct a full assessment that they will review with the on-call psychiatrist. The team, when they do go out, they can provide supportive counseling. They can transport to the crisis stabilization unit or the substance use unit. They can also provide outpatient referrals, and they can do verbal de-escalation as well. And if needed, they can transport to a hospital. Next slide, please. So what happens after the call? So after the call, the counselor will do a follow-up call. The follow-up call normally occurs within 24, 48, or 72 hours. If someone is suicidal or in distress, the follow-up call will occur sooner. During the follow-up call, the counselor is assessing the caller's current state. Are they still suicidal? Do they still need assistance? Were the resources contacted? What other supports are needed at the time? Counselors will also collaborate, if possible, with family members, their outpatient provider, or a friend as a part of the safety plan that's conducted. And if needed, mobile crisis teams can be dispatched as well through the follow-up calls. Additional follow-up can be made depending on the outcome of the initial follow-up. And if someone requests a follow-up, that can also be made as well. We often have callers request follow-up for a certain period of time. Some people may say, I feel like I'll need additional support. Can you follow up with me for the next 2 weeks? And then we schedule those follow-ups for the next 2 weeks on a time that that person prefers. So this isn't a full picture of what all our Lifeline 988 calls will entail. However, this gives a brief overview of the calls we currently receive, but we do receive other calls outside of this box as well. And I think that was my last slide.
Wonderful. Thank you so much, Quinita. Okay, if I could grab all of our panelists back on now, because we do have quite a few questions in the Q&A, and I am going to turn it over to Nova. And please note that do check the Q&A, because some of you all have asked some questions in there that Shauna has kindly gone in and responded to within the Q&A. So do check that as well. We are recording this presentation. The recording will live on NAMI Metro Baltimore's website. So we will be sharing that, and Dan has also said that we will be able to share slides as a PDF with you all as well. So everyone who's on the call, we can send that out, and we will post that to our website as well. And now I will turn it over to Nova for the Q&A.
All righty, thank you so much, Carrie. And thank you all, Shauna, Quinita, and Dan, for all of the information you shared this evening. It's really, provided a very well-rounded picture. So lots of thank yous in the Q&A. We have one question from Sam, which is, what are crisis response centers that are not inpatients? If anybody would like to try that one.
I'd like to ask Quinita to take that. I know you talked a little bit about your stabilization center or your crisis center, but that will be an example of one that exists already.
Yeah, so it's similar to an inpatient unit. They'll receive psychiatry, around-the-clock care, therapy, and groups. However, it's all voluntary, so they're not forced to stay there. They, if they're not a danger to themselves, they can leave anytime they want. And it's more of a relaxed environment as well. They can wear their clothes in there. They don't have to necessarily wear scrubs. And they can communicate with family members while they're there. So it's not as controlled as an inpatient unit.
And that is centers like that are our goal. is that we'll be able to connect people directly to a center like BCRI's, and people won't have to go to the ER first.
Thank you. And Dawn asks, how short-staffed is the lines expected to be when it first launches, I'm assuming?
I think that's a $1 million question. We don't really know how much the volume is going to increase. Everybody's trying to predict that, and it's really, really hard to say. I just think that we're all trying to increase staffing as much as possible. And I don't really know that it's short, and Queenita can talk more about this. I don't really think it's short-staffed in the moment in terms of not being able to answer calls at all. It's a question of how many calls get rolled over to the national level and how long it takes, to be able to answer the call. I don't know if you have anything to add to that, Queenita.
No, I'll agree. We're not really short-staffed now. And I think all of the call centers are working on adding additional staff so they can be able to handle the calls. All of the Lifeline calls that currently come in now are rolled over to a national line. So if a current call center isn't available, it will go over to one of our backup centers that can answer that call as well. But all Lifeline centers are currently preparing for the possible increase in call volume.
Great, thank you. There are many callers into these lines that may not need a crisis response, even a more highly trained professional responding via the phone. Persons who use crisis lines for support and not because they are in crisis. Will these callers be screened out to a different system?
Our goal is to have 988 to be an integrated behavioral health line, that's for anybody who needs to reach out for help. And I think Queenita did a good job of covering the type of calls that currently come in. If you have more to add, Queenita.
No, those calls won't be screened out. It's actually a majority of our calls. A lot of callers aren't in crisis when they call. They just need some type of support, non-crisis support. So those calls will definitely, still be taken on the Lifeline.
Okay, so this one's from an anonymous person. Are 988 responders authorized to trace calls and dispatch 911 personnel to arrest, hospitalize involuntarily? And are 988 responders / mobile crisis teams required to honor psychiatric advance directives? That's a good question.
I'll take the last one first, is that for our teams that we're funding, we are honoring advance directives. And I think that's probably standard in general. And then I don't know, Queenita, if you want to answer the first part about explain like active rescue.
So we currently don't have the ability to trace, but we do work close with the 911 call centers. And if we need to trace a call, we do provide that number to 911 and they do assist with tracing, but we don't have the ability at the call center to do a trace.
And that's something that there was a FCC hearing about geolocation and whether 988 would be given that capability, and that hasn't been decided yet. There was a lot of arguments for and against, so we'll see which way they decide.
Thank you. What will happen in regards to OMHC that use an organization like Grassroots for their after-hour call centers? Will these be affected? Should they be using 988 moving forward?
I like that question because we would love for everyone, once the system is built out and people feel really confident in it, we would love for behavioral health providers to say, instead of call 911 or go to your local emergency room, we'd love for them to say, if you're having a behavioral health emergency, please call 988. That's our goal eventually. I know we have a ways till we can get there, but I don't know. I know some. I don't know the technicalities of what OMHCs are required to have in terms of contracting for after hours care. I know everybody's required to have some sort of after hours care. So not sure that'll change, but I did want to answer that one because we would love eventually to have people say, call 988.
Mhm, mhm. With regards to substance use, are you a resource that can be called during an OD, or should we still call 911? Not sure if they're referring to 988 or to BCRI or BHSB, but if we could clarify, that'd be great.
So for an overdose, if someone's actively overdosing, I would say call 911 because they're going to need emergency medical assistance. But we could be used as a resource after after that. We can provide substance use resources or information related to naloxone. But if they're actively overdosing, I would say 911.
Mhm. I think on a similar note, there was a question earlier in the Q&A that said, will there be like mobile crisis team units available as soon as 988 goes live, and what should people expect with that?
Well, mobile crisis, each jurisdiction already has mobile crisis. And I think maybe some aren't 24/7. So our goal is to expand to 24/7 throughout the region, and really just to expand mobile response services in general so that one, their responses can be quicker and we'll be able to respond to a greater variety of calls.
Wonderful. What type of training is provided for those who would like to assist with the crisis response team?
The crisis response team, the co-responder model with the clinician and officer. Is that what they're referring to?
Not 100% sure. If this individual would like to clarify in the chat, that would be great. My guess might be either on the phone or a mobile crisis unit. What would it look like for folks to get trained?
Currently, the mobile crisis team doesn't do volunteers, but the call center does have volunteers. They receive the same training that the regular counselors would receive. They receive a ton of training, actually. The initial training is an 80-hour training where they're doing crisis de-escalation, suicide prevention and de-escalation, cultural competency. I mean, it's a host of trainings that they receive in person. They also do 40 hours of shadowing, and then they're sent out as well for assist trainings and mental health first aid trainings. And they do role plays and mock sessions, and then a ton of online modules as well. So they will receive the same training that the regular counselors would receive, and it's ongoing training as well.
Great. Thank you, Kanita. Somebody just said 988. We did get a few questions in the chat, which I'll switch over to now. Somebody asked, will this be for kids as well?
Yeah, the system already serves children, but we of course want to beef up the system for everyone, including children. We know that children and families often have a more intense need and need intervention earlier, and I know the state is working on improving services for children, as are we, but really building out those more intensive services for children will take longer, but yes, it's for the whole lifespan.
Wonderful.
I'll jump in here just real quick, Nova, and just say, Sean, I know you answered this in the Q&A, but maybe if you could answer it live as well. We are still getting some questions in the chat about healthcare coverage. You know, what about those that don't have health insurance? Are they going to find themselves with a large bill? What does this look like regarding health insurance coverage?
Yeah, that's a great question. So there's no charge ever for calling the phone, for calling 980. There's no charge for you know, mobile response teams. Insurance actually doesn't cover mobile response teams at this point, although I think some places have figured out how to bill through Medicaid, but there's no private insurance coverage for that. I think the real problem for people who lack insurance will be in finding the follow-up care. We all know there's a shortage of providers that serve people who are uninsured. So I think that's the bigger problem. The other problem, I don't know, Dan, if you heard this during community engagement, I know if someone calls and there's an active rescue that requires an ambulance ride for like a medical reason, then obviously then I think that person could see a charge for that. But no charges for for 988 or mobile response teams.
Great, thank you. Oh, Dan, did you want to add something there?
Yeah, just to reiterate, I mean, we can talk about the charges for the crisis services, but it's still like integrated or, you know, part of our broader healthcare system. So ambulance ride still might cost something. If you go to the emergency room, that'll cost something. And, you know, ideally you probably would want services on an ongoing basis afterwards. If psychiatric medication is a part of your treatment plan or ongoing counseling or therapy, that will continue to be, you know, part of our system as it exists today.
Yeah. And oh, sorry, Shauna, anything else to add there?
Oh, I was just gonna say in terms of the comment in the chat, I mean, a person can call 988 as often as they need to call without any charges. I mean, I would say that we can't, GBRICS is really focused on this narrow part of it in terms of like ongoing behavioral health care. And the cost for that's something that we're not able to tackle through this.
Absolutely. And then another one that has come up in the chat is, you know, the difficulties in the system with only helping those who are willing or who are suicidal or in danger to someone else. And, you know, do you see any new guidelines on the horizon to be able to assist those who are unwilling to get assistance for themselves or are not in a place to make that decision? Shauna and Dan, anything on the advocacy level that you're seeing there?
So GBRICS isn't really changing any of the existing legal framework for that. I'll say what we're hoping to do is to be able to provide better or kind of enhance counseling for family members to help them in a time of crisis, providing support and guidance. But and we're hoping just by providing some guidelines around that and also being able to increase the number of people taking calls, increasing the number of mobile response, that we'll just have more staff capacity to help. Dan, I don't know if you have anything to add to that.
No, I mean, there are lots of efforts out there to look at the emergency petition standards, how, like, use of force by police, like there are groups out there that are considering those issues. But the GBRICS partnership and 988 launch, like, that's like enough to work on. So we're not wading into any of that, although we do see that the current standards, you know, like there are rationales on both sides that so but if folks are concerned about that, like, there are groups out there that are looking at you know, when and how people can, like, involuntary treatment can occur.
Great, thank you. I know that could lead into a whole nother presentation,
Yeah,
right?
nope. Too late for that one.
Don't have time for that tonight, but we can schedule another one for that. Nova, I'll turn it back to you. I know that we've got a couple more in the chat there.
Great, thanks. Did you already answer the question? Is there competency for the call center and or the crisis response for minority groups like trans and LGBT, immigrants, elderly, etc.?
So we do a ton of training for special populations, and we also have a very diverse workforce. So we have a ton of peers on our call center. So I would say about 60% of our counselors identify as LGBTQ+. We have a broad age range. So we do a ton of training related to special populations, and we also have several peers within our call center as well.
That's wonderful. Shauna, did you want to add something? It looked like you. Okay, great. And are there any new modalities to prevent high utilizers or abuse of the system?
Not currently with our call center. We're tracking high utilizers. And normally when that happens, we put a care plan in place. We still want them to use the lifeline, because just because they're high utilized doesn't necessarily mean that they're never going to have a need or a crisis. So we normally, when that happens, we just put a care plan in place, and the counselor has a specific script as to how to work with this person if they're a high utilizer.
Yeah, in one of the biggest promises of expanded and strengthened crisis system is to reduce emergency room use. So that's where you see the biggest impact or the biggest cost impact of high utilizers is in cycling in and out of the hospital. And so the hope is that if with a more robust regional call center and additional mobile response teams and more resources in the community, that people can get their needs met without needing those higher levels of care.
I think one last question in the Q&A. Could you provide some insight on what the regional standards for crisis response would look like in the future? What would you hope to establish as priority?
Not sure about priority. The crisis, the GBRICS crisis standards are on our webpage. If you go under the resource section, it's a pretty lengthy document. But I'll say in terms of one of the big things that we're hoping to change with the crisis system is increased accountability. So, and transparency. So forums like this explaining how the system works and then being able to collect data and share that with everyone, so that we all know what's going on with the crisis services and we can all advocate for the additional services that we need. So I had to say the biggest priority for me, that might be it.
Great, thank you. Well, thank you for all of your questions. I know there are still a few more, but we've got to wrap up. We're almost at time. But please feel free to keep in touch with us. And on that note, I will share some information. And thank you all panelists for your well thought out questions. These are our upcoming events that NAMI Howard County, NAMI Carroll County, and NAMI Metro Baltimore have coming up. Please stay in touch with us. We've got support groups. You can obviously find local ones at your local NAMI, so be sure to look out. There's going to be a movie screening coming up in October, and then NAMI Metro Baltimore will be launching our education classes later this summer, early fall. If you want to scan here, if you happen to have your phone on you, just to get our newsletter, you can be in the know about all our events that are coming up. We've got an LGBTQIA plus mental health chat with the experts on June 30th. And it looks like NAMI Howard County also has a great event coming up in July about finding new meaning and perspectives and healing through the lens of history, racial trauma. So be sure to check them out. And of course, if you missed any information tonight, we will be posting a recording of this, and you can find all of this information there as well. I almost said next slide to myself. Here is our contact information. You can reach NAMI Monday through Friday, 9 to 5 at 410-435-2060 or 00, and we will obviously connect you to the correct resources. And then we've got social media handles. Please follow us and please reshare any information that you think is helpful to community members. It really takes all of us to make a difference in supporting our community's mental health. So thank you all. You are clearly advocates, and we are really grateful to have you in our corner. And this is just the beginning. There is much work yet to be done. And I will turn it over to Carrie if she has any closing remarks.
Wonderful. Thank you. I just want to thank everyone again for being here today. And I'll just end it reiterating what Nova said, which is it takes all of us to help spread the word. Again, this won't be launched until July 16th. So please hold on spreading that word until then. But once it launches, please help us spread the word far and wide, social media, email, through your workplaces, home, communities. We're going to need everyone on board to launch this the right way. So thank you to all of our presenters for being here tonight, and to everyone for interacting with us throughout this entire presentation. I know I learned some great things, and I am excited for what's ahead. So thank you.
Thank you.
Thanks,
Thank you,
everyone. Have a great
everyone.
evening.
Bye-bye.
Bye.